So our final speaker for the day, it's my pleasure to introduce Dr. Mark Doherty, who is the Executive Director and founder of the DentaQuest Institute Safety Net Solutions Program, which is now part of DentaQuest Partnership for Oral Health Advancement. Under his direction, the program has grown from a local pilot in Massachusetts health centers in 2005 to a national program, now serving over 400 safety net dental programs in over 44 states. For nearly 30 years, Dr. Doherty served as the Director of Oral Health Services at Dorchester House Multi-Service Center in Boston, Massachusetts, where he built an FQHC Safety Dental Net program that included several treatment sites, innovative service delivery models, including specialty services, an integrated healthcare network, and also assumed responsibility for other Boston Community Health Center dental programs. Quite accomplished gentleman. Dr. Doherty will present Cracking the Code, Oral Health Value-Based Care Transformation, Putting Value into Our Dental Visits. Please join me in welcoming Dr. Mark Doherty.
Thanks, David, and thanks all of you. I've kept my record intact. So for 14 years at DentaQuest, I still am not the smartest person in the room. In fact, after this crew today, I feel like Jethro Bodine Clampett. So I'm going to jump right into our subject matter today, which is oral health value-based care. For the past 3 years, I have been studying value-based care. And of course, most of the literature, most of the evidence is in medicine. So I've been looking at what that evidence tells us in medicine and coming up with a few things. First is, currently, there is no one model of oral health value-based care. It's not cookie cutter. We're not going to walk in the room, flick a light on, and think that one model is going to work everywhere. We really have to look at our patients, their needs, our structure, our capacity, and design systems that will meet their needs. Second thing is that there's a paradox, and we've talked about this all day. You know, this is different. In the United States, we're used to paying more and getting better or more. But with the value-based care paradox, we're going to try to add value to care and reduce cost. And that's tough to do because dentistry, as we talked about today, is very expensive. The last part is the question. So, is a value-based care methodology better? Is better better? And as I have learned over these past 3 years, the design of the system is going to be what determines that. So value-based healthcare is actually a delivery model in which providers are paid based on making their patients healthier and reducing the cost of care. And in this, I just want you to notice that we mentioned providers, payors, and patients, because as we design systems, it's going to be imperative that we think of all the stakeholders as we design the system. People won't stay involved, either as payors or providers, if they don't get what to them is their win, what they feel they need to get to support it. We talked about this, saw this several times today. So I consider myself a practicalist. I'm very optimistic. I always think that no matter what the problem is, we can create a solution and actually do better. I believe in singles, doubles, triples, and home runs. But if we can make what we're doing better for everybody involved, just a little bit, if we can move that needle, that's good. We're always trying to move the needle as far as we can, but doing better, being more efficient and effective counts. So for 219 years, we've been in a fee-for-service reimbursement. As a fifth-generation dentist, my son is a sixth. Hopefully my granddaughter will be a seventh. We have all in our family been in a fee-for-service reimbursement. Not only did I work at the Dorchester House Health Center for 30 years, but I also had a very large and robust portable practice in Massachusetts, with 8 dental teams that went out every day to 350 sites to provide care only to children that didn't have care. That was, I think, the innovative part of what we did. But it's not easy to put all those things together and make it work. And it certainly wasn't value-based, and it still isn't. It's based on fee-for-service. And as long as we're paid that way, what we do will stay the same. I told you the paradox is we would like to pay less and get more. Well, in oral health, which is very expensive, not easy to do. So we have to think this through, and we've seen different models today that show us what that might look like workforce utilization in different ways. And what if the way we were paid, even in fee-for-service, changed, and prevention and management and motivational interviewing and behavior change were all paid at some level, and crowns and the high-level procedures maybe dip down a little bit. But to make that happen is certainly a challenge that I don't think we're there yet. So I loved this when I first saw it. I'm kind of cavalier, and fee-for-service pays us for what we do. Bill Riley, Dr. Bill Riley at the Safety Net Advancement Center at Arizona State University used this in one of his presentations. And that value-based care pays us for what we don't do. And yeah, it's cavalier, and when I first saw it, I understood it. So yeah, we want to keep people healthy so that we don't have to drill and fill and bill our way to success. And what does that take? But still, being Jethro, Bodine, and Clampett, I have to take a step back and look at it professionally. So it's really about providing care that makes our patients healthier. And if I'm in a room and I talk about that happening, and people are in that room that are smart, they're going to say, what? Prove it. So it's all about how do we prove that we're making people healthier. Taking another step back, we've all mentioned today several times that the value-based care methodology was created for medicine. And so as I looked at that, I said, so why? I kind of knew why, but let's take a look. So first of all, the why is that the cost of healthcare is off the charts, and each year gets more challenging. 3.3 trillion was 3.25 trillion was 3.1 trillion in the last 3 years. 88% of the provision of health care that we provide is in access, but we know that access only improves health 10%. Changing behaviors improves health 50%. And then as we look at Medicare, and we look at the figure that in the last 6 months of life, 50% of the Medicare budget is spent there, it's like scary. So that's why health has been challenged to move to a value-based methodology. So the people that sign the checks for health have said we need to change what we're doing. So let's take a look at physicians in medicine and dentists in oral health and some of the demographics, because this tells a story that we should all know. There's about 1 million physicians. There's about 4 million nurses, 100,000 nurse practitioners and PAs, 130 specialties. And then in dental, we have 170,000 dentists, 205,000 hygienists, very few dental therapists, and only 9 specialties. So size of the workforce is tremendously different. And as Beth told us, hey, the costs of providing care, no matter where you're doing it, is in the people involved. So the 3.3 trillion is accounted for there. As we look at the $3.3 trillion budget, we look at the fact that in medicine there's 5,500 hospitals, that those have about 1 million beds, that they do 35 million admissions a year for $1 trillion. And there's 561 ACOs in medicine, up from, I think it was 470 a year and a half ago. Whereas our budget in oral health is only 4% of that 3.3 trillion, or 128 billion. Last figure I saw was actually 131 billion. Significant, but pales in comparison to the 3.3 trillion. Also, that 50% of physicians are employed, so that's a different relationship. Whereas still in dentistry, and this is arguable, somewhere between 70 and 80% of dentists are still in the private practice of dentistry. And we do know that DSOs and corporate practices are growing. I don't know exactly what the number is today, but I know that as a trustee at the Mass Dental Society, when I talk about this to the private dentists in the room there, they don't want to hear it. They don't want to hear about change. They don't feel urgency. They feel that, hey, it's working for me, let's keep it going. So we have to consider that if even 60% of dentists are in private practice, in 1 and 2 dentist practice, what's that going to look like to design a system to apply to them? And to me, that's the big challenge. In our networks to provide care, what's it going to look like in the mom and pop practice as opposed to what Mike and John have done at Kaiser and Willamette? You know, they put it all together, but they're huge, they're big. So when you do it on the microscopic level and try to make it apply and then implement it, it's very challenging. Also, the ADA can be a barrier to change. They represent their constituents, and as we know, most dentists, and Jack referred to it today, we can be selfish. And if it's working for us, don't change it. When I ask dentists at the Mass Dental Society how the quality of their work is, they say great. And then I say, how do you know? My patients love me, and they keep coming back, and they don't complain. And on Yelp, I get 5.0 out of 5.0. They don't talk anything about any of the measures we talked about today. It's not in their lingo. It's not in their culture. Medicine has Medicare and Medicaid. We exist primarily in Medicaid, not in Medicare yet, although we're looking at that, and hopefully we're going to get a benefit. And also, we mention this all day today. So by the World Health Organization, we're ranked 37th on the outcomes of our care and health. And, you know, we asked, do we have the best dentists in the world, and do we have the best physicians in the world? I would argue yes. But because of the way we're paid, we don't get to act that way. You know, as I got older, working at the health center, listening to Sean about the culture of care, thinking about my experience at the health center, I look back and I say, man, did I miss a lot of opportunity there to connect with my patients in a different way and to show them and lead them to better health and oral health. But I was susceptible to the demand of, you know, as Sean, as you said, I thought of several of my patients at the Dorchester House if I said to them, so Manny, what matters to you? He'd have looked at me and he said, what matters to me is you take care of what's the matter in my mouth. You know, he's not going to think beyond that. So I never made the connection where I could get him to think about that a different way. And that's my biggest regret as I think back of those times. The value that could have been created, I missed because I was giving way to the urgent asks for 162,000 people living in a 6-mile radius, all of whom qualified for nominal fees or sliding fees, and all of them wanted to be seen yesterday. All right, so take another step back. This is what I've learned. Once again, this is subjective to me. I'm a practicalist. What I've been used for is to implement different models of care. So, oral health value-based care is not simple. It's very complex. So what does that mean for us who probably will be at the table helping to design what it's going to look like? And that is, well, we have to know all of the components, the domains, the competencies, what goes into it. As I said before, it's not one size fits all, as Jack mentioned. He's got a practice with 700 offices. They build a new practice, and they're going to treat patients with special needs. Well, that care model is going to look different for those patients, and probably the finance model has to be thought about to be able to provide the care to those patients that he wants to provide. It's not guaranteed. There's as much evidence in health about failure of value-based methodology as there is about success. To us, that just means beware. Take a step back and learn from health. Learn why there was failure, learn why there was success, and standardize the predictability of the things we use, the initiatives we use to set up our system. It's not going away because of the cost. So the people that pay for health are asking us to look at this in a different way, and they're saying, look, we want a value-based methodology. So at our business, at DentaQuest, each year, and Allison mentioned that we're in 30 states, each year more of those states for whom we administrate programs ask us to include a value-based methodology in the payment system. And then each year, ones that we're doing that with ask for a higher percentage of a value-based methodology. And that is why, principally, our team has changed from fixing the system in fee-for-service to really taking a deep look at a value-based care methodology and how to be efficient and effective there. And it's not instant. There's a curve. You don't go from fee-for-service to value-based overnight. You're going to travel at some point, you're going to pass in the night, but it's all about being efficient, and you're going to need financial strength to make that happen, because there probably will be some voids that happen because of it. So I mentioned there are domains of value-based care, and everybody looks at leadership and they say, well, yeah, no kidding, leadership. No. We need to lead through change. We also have to understand the domains and competencies involved in value-based care. We have to define what success is. That's our vision. And if it's going to be tough, we're going to have the will, the steel to make it happen. We're going to hang in there. Also, we're going to have the capacity. So in this system, we're liable to be assigned 1,000 patients, 10,000 patients. Do we have the structure to treat them? Because if we accept 10,000 patients, but we only have the capacity to treat 2,000, the care they get is going to be anything but valuable. And we have to get provider buy-in. So those providers that I talk to that say, hey, tell me when this is going to happen, but until then, I don't want to hear about it. How do we get them to buy in? And then how do we teach them how to provide value-based care by the creation of pathways internally in the programs to make that happen? We have to have, as we've mentioned all day today, the big challenge. This drives Sean nuts. Data analytics, interoperability, technology and personnel to run that. If we can't evaluate our programs, if we can't monitor our care, if we can't document our care and report on our care, it's not going to work. And the last is, as I mentioned, we have to be financially strong enough to make a change, especially a systems change in a system that we've used for 219 years. I mentioned transition. We saw transparency, transition, and transformation. I just wanted to mention that. In my estimation, we're going to need to be transformative and transitional. And to me, transition is going from wherever we are now to somewhere we see, understand, or have been, and taking with us those things that are efficient and effective in the system we're leaving, that we need to be effective in the system we're moving to. The transformation is going from where we are now to a system that we don't understand. And so there will be parts of oral health value-based care that will be new, that will need new policies, procedures, operations, and systems to actually operationalize and implement it so that we can be successful. As I mentioned, Sean showed me this one day. It was pretty funny because I was doing my usual reading and I'm looking at it and I see too much at once. For some reason, Sean gets to look at it and he just boils it right down. But when I did look at it, I laughed. Jackson, this is us. We've lived and been treated in all three systems. When I was a young kid, the doctor used to do house calls in my house. When I was sick, the doctor came, listened to my heart and looked at my ears and my nose and took my pulse and gave me some medicine or said behave or whatever, but he came. The second is in health centers. So yeah, I was part of the patient-centered medical home, part part of patient centricity. I learned the chronic care model. Hell, if I hadn't gone to the health center and if I hadn't been involved with NOAA and Safety Net Solutions, I just would have been plugging holes like I was for many years. And then the third part is I get to hang around with people in this room who really do understand what a culture of health and wellness is. And as I look at that, and I look at what Mike does at Kaiser, and what I heard today happens at Willamette, they've got to figure it out. Well, we have to figure it out too. And it's not easy, but if we're persistent, and if we create pathways for a culture of health and wellness to happen, we can be in a good place. As I mentioned before, I just laughed, Sean. Some of my patients at the Dorchester House, if I asked them this, it would have been, hey, fill what needs to be filled and I'm out of here. My opportunity was to have a different conversation with them, but I probably kind of got a kick out of it. All right, so this is an opportunity for us. If we don't see oral health value-based care as an opportunity, we're missing the boat. Because at this point, depending on who you talk to, less than 5% of oral health is financed in a value-based payment system. Okay, maybe it's 10%. But I ask people and they say 5 to 3. I just know it's not a lot. And what we have to do is we've got to make sure that smart people who understand care and what makes people healthy are at the table determining, excuse me, what those metrics are, both operational and quality. The fact that something is different is an alternative payment methodology doesn't mean it's right. It's going to be about the design of that alternative payment methodology. What makes people healthy and is affordable? What's that going to look like? And as Beth, Sean, everybody brought up, what makes the experience of care better? Can't miss that boat. So we've talked about fee-for-service today, and a lot of people talk about it like it's a bad thing. Well, there are parts about it that work. And so if we look at it, what works? Well, number one, when you provide a service, you get paid for doing that. That's not a bad thing. And if patients need more services, normally we can provide that. Also, the payment doesn't depend on variables that we can't control. So if our patients don't maintain their oral hygiene and are not compliant, then they still get paid. And they should. Although, in the value-based methodology, the emphasis is going to be on then getting that relationship with the patient to make them compliant. And that we know, based on the rules, what the payments are. So if we can't afford to provide crowns because of a Medicaid reimbursement, we can make a decision not to do that. But it's a choice. What isn't involved, and why we're talking about this, is there's no link to quality. It's all linked to volume, as we saw on the left side. Also, the care is not predictable. So Dr. Ritchie might diagnose the patient and provide care, and Dr. Doherty might diagnose the patient and provide different care. So without those diagnostic codes to help guide us, we're all over the place. Also, many things that we need, like motivational interviewing, behavior change, aren't paid for. And the last part is that the costs of care are not predictable. Based on my practice could have a staff of 10 and 4 chairs, and cost is higher there than my friend who has 4 chairs and a staff of 6, stuff like that. All right, so pay for performance, and I'm jumping ahead a little bit, I apologize. So pay for performance is one little method of providing value-based care, and I'm going to jump ahead to it here before I define it, just to show you that it's not perfect also. And so it might be a bundle of 5 services that the contractor, the payer, and the contractor and the providers agree okay, these are gonna make people healthy. And remember, I'm not gonna sit here and debate Beth Mertz about what makes people healthy. But I'm Simple Simon. If I'm designing a system, something that's better and in a better direction might be a first step to get us to where we're actually having measurable outcomes that show us that we have made patients healthy. So what is evidence-based care? What the literature says, what the people we look up to in the world of oral health says is the right care, and what the patients say. And if we agree on that, that might be something worthwhile. Once again, something is better than nothing. The something is what we have to think about, and the way I would think about it is, in year 1, these are the somethings. In year 3, these are the somethings. In year 5, this is what they are. In year 10, we're really there. So, pay for performance might not be the services that patients need. Jax might have a pay for performance bundle in Arizona for his patients with disabilities that doesn't provide them the care they need. It might be designed for patients that don't have disabilities. What about those payments? Actuarial precision was mentioned by Sean. If we don't figure out exactly what providers have to be paid to be profitable, what payors minimally can pay to handle costs, and what contractors who are involved in the middle can get so that they're profitable, it's not going to work. So that actuarial precision is paramount. In fact, I get asked a few times, one of the big questions is, all right, so you studied this for a while, rank what's the most important? And I always say actuarial precision. That per member per month amount has to be spot on. It's got to save money for the payer. It's got to be enough for the contractor to be profitable, and it's got to be enough for the provider to be profitable if they do it right. If that isn't, if it's wrong for any one of them, they're out. I think the easiest part is to figure out how to make our patients healthy. I think the toughest part is the business piece, that if we do figure it out right, we're going to provide more value-based care. So once again, costs aren't predictable. It could be all over the place depending on what Doherty does and what Sean does. If we have patients that have a lot of needs, we could actually be being paid less than is required to provide the care they need. So that actuarial precision needs to be figured out. So let's take another step back and look a little bit at oral health value-based care 101. And I talk about this all the time, and Allison referred to it earlier today. For this to work, there has to be a win-win-win. Oops, sorry. And that is payers have to be comfortable. Contractors, MCOs, DentaQuest, Aetnas, Avisa's have to be profitable. Providers have to be happy with the care they're asked to provide, and they have to be profitable, and patients have to be provided care that, when we document it, proves in some way, shape, or form that they're better off, they're more healthy. Are they totally healthy? Is it a home run? I'm not sure what that would look like, but it has to make them more healthy, and based on evidence-based, based on the people and the evidence in the literature and what patients tell us makes them healthy. So in value-based purchasing, what the payers want, there's no surprises here, and I'm going to whip through it, but obviously lower costs, which means a decrease per member per month. Remember that in a value-based payment methodology, if there is a prospective payment, that means you're paid at the beginning of the month to provide for the patients you've been assigned the treatments, the services that you've agreed in the contract to provide for them to make them healthy. So, some percentage in the contract, it will say, of the 1,000 patients assigned, you're going to be expected to see 70% of them. Of the 70% you see, 90% of them need to get a carer's risk assessment. Of the children with elevated risk, 90% of them have to have 2 fluoride applications. children that need sealants get sealants. That type of methodology. Also, they want broad provider networks. You know, it's still about access. States and insurance companies don't want people complaining that they can't get in and get treatment when they want it or need it. The benefit package, what we actually provide, what could that look like? What value-based procedures, quality metric, agreed upon procedures could be in that benefit package? Everybody's trying to stretch. So we want increased capacity, we want increased access, and also increased services, but lower cost. We want to decrease disparities by the way that we provide care. We want the value-based health center practice to look like the private practice down the street. We want to increase preventive services. Our focus is on keeping people healthy, once again, so that we don't have to provide surgical intervention at the rate that we did in the fee-for-service reimbursement. And we want to be able to demonstrate across all of our quality domains that we're doing better. So the experience of care, the care provided, and cost management and containment, and safety of our staff and of our patients. And today's patient is much more empowered, enabled. The young patient of today kind of gets it. They know what healthcare and oral health care should look like for them. They ask questions. The questions are smart questions, and they want answers. All right, now we move to the contractors. So if we're a contractor, if we're a DentaQuest, what do we want? Well, give us goals that are practical, doable, measurable, meaningful. We need to be profitable, or this isn't worth doing. We need normal contract provisions for operational and process measures. Oops, sorry. And we need an RFP that's clear, once again, reasonable, down to earth, not esoteric, not theoretical. Everything needs to be tried and tested and proven and agreed upon by the DQA and the NQF and all of those people we look to for direction that, yeah, this is the stuff that does make people healthy. Contractors hate the fact that there's great communication while the contract is being decided, and then all of a sudden it happens and everybody disappears and there's no more contact. So if there's problems, it's tough for them to get direction, and sometimes they're not allowed to contact patients or providers. So, you know, a true partnership doesn't act like that. And if we're going to have a value-based methodology, those partnerships have to be built on trust, comfort, confidence, and communication. Clarity related to those expectations. How many of us have been involved in a contract, an MOU, where it didn't delineate responsibilities and we ended up in a, I thought this, you thought that, and they were both divergent and it didn't work. Once again, pre-procurement lines are open of communication, but then after procurement, those lines are still open. So with the payer, also with the providers and the contractor. And we need that actuarial precision. The number has to support the care, has to support our people. The number that we're going to get paid has to be enough so that we are profitable. And those dentists that I work with at the Dental Society, if I go in and say, hey, I have a way for you to be better in the way that you treat your patients, but to do it, you're going to make 30% less than you did last year. That's a hard sell. So it doesn't sell. Lynn's laughing like mad, yeah, right? We're showing the door. Okay, and yeah, so how we assign patients? Once again, we want to be assigned patients according to the capacity we have, but also historically. I don't want to get a whole bunch of new patients. Like in my own experience, I built up a patient clientele over years. I wouldn't want that to disappear because I was using a new system of care. I want those same patients, their families, to be my patients, to be our patients. All right, so then what do patients want? So the patient of today, and in actuality, this could be updated, but patient of today wants convenience. So it's really funny. In 1974, I was asked to create a school-based, children-based, portable oral health system in Massachusetts that went to the Department of Youth Service, Department of Social Services, Early Head Start, preschools, pre-care, YMCA, Boys Club, Girls Club, schools, Boston school system, Raoul's, and I sat down many times to figure out what that would look like. But the other dentists in Massachusetts were not happy with that because it was different. How could you provide quality care if you weren't doing it in an office? Well, we've come a long way since then, and it's more acceptable now. And so bringing care to where patients are, whether they're a disparate population or whether they're patients that have jobs, work, and are looking to not have to leave work for care. So looking at it differently and providing care differently is happening, and patients appreciate that. They want accessibility, so when they need to be seen, they don't want to have to wait 3 months. If they have 3 restorations that they need, come on, you can't ask them to wait 3 months. They want it now. They would like quality, and they also want care to be equitable. They're looking at what their brothers and sisters and mothers and fathers get if they're going to different practices, and they don't want it to look or feel different. Patient-centeredness is totally awesome, and when you do practice it, there's a feeling from it that's different. In my own healthcare at Partners, it's totally patient-centered. It's like nirvana. It's wonderful. I have the greatest healthcare, which I need, that you could imagine, but I'm very lucky, and they do it right. And it's all patient-centric. I am part of my own choices relative to my health. I'm part of the equation. I get to give input, and that's what patients like. They want care to be satisfying to them. They want it to be timely, as we said. They want to give input, and they want it to be safe. What do providers want? Well, there's no surprises here. Person-centeredness. They'd like it to be standardized. Wouldn't it be wonderful if all 50 states had a standardized approach to Medicaid payment and reform? Are you kidding? But, we're all over the place. They wanted evidence-based. Yeah, tell me what the evidence says. That's the care that I want to provide. They need it to be financially rewarding. Why shouldn't it be? And look at the debt of students today. Oh my God. I got out of dental school, I had no debt. I fished for 6 months a summer, and I made twice what it cost me to go to dental school fishing for striped bass and tuna fish. It's like, when I saw my son graduate, I remember he called me up one day and said, Dad, I'm going to endo school next week. I need a microscope. So I'm thinking, go down to Woolworths and buy a microscope. He says, no, it's a $35,000 endo microscope. And I had to pull over and say, holy moly. So things have changed. We want it to be measurable, obviously, ethical. And those care expectations need to be in the contract, clearly delineated, no surprises. All right, so what happens in the contract? I'll whip through this. So you assign patients, numbers of patients. You're going to be compensated usually per member per month, prospectively, meaning in the first 10 days or 15 days in the month. Excuse me. And that's going to cover the care that you're going to provide in the bundle or the paid performance metrics. There will be minimal operational metrics. In other words, if you're assigned 2,000 patients, you'll be expected to see 70% of them. And if you don't, your per member per month is reduced, if the contract says that. Also, there will be quality-based metrics, and we've talked about that today. I'm not an expert start there. I'm a practicalist there. I know, once again, if it makes things better and if we can get the program going, let's do something. Something is better if we design it right, and then let's build it over time. And what are we going to do about specialty services? That would be in the contract. And the way that our services are monitored is by usually sending in claims. However, it can be different if we have the technology to report on care. And it is monitored. So it's just some quick health finance terminology. So once again, getting a prospective payment is getting paid up front, the beginning of the month, to do certain things you've agreed to do to your patients and to see certain numbers of patients based on the contract. An alternative payment methodology is a different way of getting paid that has value in it. At first, I just thought it was anything different than fee-for-service. But the way it's defined is a value-based payment system. Fee-for-service, we all know. Is there anybody in the room that does not understand how health centers are paid on an encounter basis that would like to know? All right, everybody knows it. I won't go there. And then per member per month, which the SIN word there is to say capitation, but a per member per month methodology is how that happens. And then value-based payment, value-based care, value-based reimbursement, that's all the same thing. It's just getting paid to make patients healthy and contain costs, and it's defined. That pay-for-performance bundle is defined. I'm going to show you a couple of models in a couple of minutes. How much time do I have? 7, okay. I want to get to the 6, all right, I'm on. All right, so I just want to get to, I want to get to some models and show you some of the models. So we're all very familiar with operational metrics. How many people do you see? What percentage of care is diagnostic, preventive, or therapeutic? How are we judged on our quality, and what are those quality metrics? They're going to be in the contract. So once again, the contract is going to tell us how many people we treat, how we're getting paid for it, what the operational measures are, the number of people we see, and the percent of diagnostic services, et cetera, and the quality-based incentives. So we also looked at the land. Once again, this is one thing I was looking at, and I was in my office, and I was talking to Sean on the phone, and I was struggling with this, and he said, you know, Mark, when you look at the land, it's a blend. You know, look at it. Remember, it was created for health. And there isn't a good connection there. But if you take a look at this in a different way and you just create a menu of all of those choices, then you choose from the menu to create the best value-based program for the patients you're going to be treating in the environment they're in. And that makes the payer happy, the providers happy, and the patient's happy. So some examples. The first example is fee-for-service and per member per month. So the blend is there's some fee-for-service and there's also some per member per month. And the per member per month is used to make up the reduction in fee-for-service that occurs so that you can build in a situation where there's bonus or risk. So in this particular model, fee-for-service is reduced 75%, but there are 5 metrics, 1 operational and 4 quality dental service metrics that you can achieve on and actually make your 25% up. And if we choose them right, and they are value-based, if they do make our patients healthier, then we're on the way to providing care that does make patients healthier. And in this particular model, I just have them, I already mentioned them. One operational is, let's see, 70% of the patients assigned, and that kids getting sealants, get sealants, and in the contract it'll say what percentage of kids needing sealants get sealants. So what if we have assigned patients that represent a population? as I did in Massachusetts. So I treated all of the institutionalized patients, children, in Massachusetts Department of Youth Services and Social Services. However, it was all fee-for-service, and still is. But we're talking and thinking about what would that look like if it all of a sudden became a value-based methodology. And for those children, based on their risk status and stratification and their history, what would be the best treatments for them? What would that look like? And that could go into the contract. The integrated delivery system is what we can do in health centers. It's certainly at Kaiser, which I think is the best model, my favorite model, Mike, you know, that I'm always yapping at you about that. But so it's an integrated finance and delivery system. They are the payer, they are the provider of health, oral health, and is it behavioral health also, Mike? All in there. Yeah, it's like, man, nirvana. That's what we all need to aspire to, but we ain't getting there in the next couple of years. We're going to figure that out. What would that look like? And so in the models for health, there are payments, bonuses for investment in IT and for reporting if you make that investment in IT from that IT. So that's just a way to get a bonus, but that disappears after a year. But in health, that was very frequent. A population-based payment for patients with conditions. So Jack has patients he's treating that have special needs. In Massachusetts, there are a couple of programs that treat patients also with special needs. They are paid differently. They get a per member per month for those patients. They're institutionalized. They have disabilities. So for them, the people have sat down and said, for them, this is the services we want to make sure that they get. If they need other things, all right, that's outside of the bundle. But in the bundle, we're going to make sure that they all get the following services to make them more healthy based on their challenges. So what are the major challenges? The one I get, and I got pushed back on, is, so is this all capitation and, you know, sheep's clothing? And I would say, no, if we design it right. All we have to do is design it right and we're all set. The win-win-win-win has to be considered. If any one of those partners or stakeholders loses, they're out and the system will break down. So, you know, there's a lot of smart people that argue about what makes people healthy. I say, well, you know, let's get in a room and figure that out and let's get a starting place. Give me 20 metrics that we can choose from, and then let's start to build some systems. And then the tough one is the independent dental practice, the mom and pop practice, the my uncle, my grandfather practice. You know, how are we going to design value-based care for them? And that's it. Thanks.
I think one thing that's been on my mind as I think about value-based care is it feels like it's putting a lot of responsibility on the provider, which of course there should be, but I don't see how it's taking into the social determinants of health that just getting patients to that clinic is a significant hurdle, and that providers could be punished because the patients are facing barriers the provider doesn't have the resources to tackle. Yeah. So how does value-based care consider those issues?
Well, a couple of things. I want you to know that I presented to an audience that beat me up on that because they said, hey, this isn't going to work because the patients that you're talking about aren't compliant and don't come for visits. So that was, you know, that's where they were coming from. But I would say that the language I had in there about communication between the payer, the contractor, the providers to create a strategic plan to help empower, enable, and get patients in would be a start. I know that in my own situation, in my own health center, I did an integration with pediatrics, and I just saw all the kids that came to pediatrics. So I captured them because they were seeing the peds.
So should there be something built into it that, I mean, because the first person I think is that you would have a social worker, a community health worker, something, you know, CDC, community dental health coordinator. Is there something built into, or the plans might be considering providers demonstrating the attempt to help patients, but you might not be successful, you know, that the attempt is as crucial as the actual doing?
Yes, and so the good news there is there are several models that I'm aware of that are being created to help that process, to help those patients get navigated into those visits and into care. And it is with the utilization of, you know, a health worker.
Quick comment and one question. Comment to the social determinants of health issue. I think with some of the community health centers, I know nationally, they have implemented the new PAR system where you can encompass those social determinants of health as far as being able to make that assessment. So I know that that's their availability currently for systems. The question comes in mind as it relates to, you talked a little bit about the encounter system as it relates to community health centers. And so my question is around what impact you think that would have if we move to a value-based system. My concern is that, having practiced in Texas, there was an insurance entity that provided coverage for adult patients. It was like $500 for dental care. And so it was a problem at the community health center because we were encounter rate, and our encounter rate at that time was $195. So the patient comes twice, and that's eaten up. So the reconciliation, you know, part, how do you fix that? Because ultimately we want to do good and we want to provide care, but we had to inform the patient, you know, you come to us twice, that CUMP exam and x-rays, and then, you know, God forbid they have periodontal disease. Well, we can't even complete the beginning treatment. Mm-hmm. So I'm just wondering how that plays a part as we talk about value-based care and how the encounter rate is for community health centers.
Well, I actually think that health centers, especially the ones that, the 75% that are reimbursed by an encounter rate, have a great potential to put value into those visits. As you mentioned, right now, the visit isn't defined by what happens in the visit. So we know that there's a lot of audits, and those audits look at bundling and churning, and it can be very adversarial to the health centers. I would say that if I was back at the Dorchester House, I would put bundles in all of my visits so that those patients at the visit were getting something commensurate with that $195. By the way, last year, Laura, was the first year that health centers, the average was $200 for us to see a patient in dental. That's a lot. But once again, if we put value using relative value units and quality metrics into the visits, I think health centers would be a great place to pilot value-based care, because all you got to do is agree. All right, let's do these things for comprehensive exam, periodic exam, RVUs. I need 7 fillings. Okay, we look at them. The RVUs, it's a 45-minute appointment, 4.5 RVUs. Do those services. And so, in fact, Jack, we created some bundles at HE Still for our potential pilot that looks like that. Even though it's not a health center, it is a dental program at a school that is similar. So that's an opportunity.
So Alejandra Valencia from the Oral Health Forum here. I just want to comment that I think you make a point about in Chicago, for example, we have been piloting a model where we took the community, specific communities, and learn about the determinants of health that those communities are facing and start working, developing a pilot, helping families to overcome those barriers to be able to get to the dental office. Because the comment that you get very often is, dental is not my priority. Right now, I need food. I need, help with other things. So once you help the family to get ready for give the next steps, they are willing to do and more than happy to do it. So I think we have been able to prove the effectiveness of that model, but I think the system is not ready yet, at least in our area, to take, those MCOs, still working with fee-for-services for dental, are not ready yet to take, the approach. So not sure how can we keep moving the needle,
Sure.
to be able to push the system.
I think one way is to change the way we use our workforce. And, to train our medical assistants, our dental assistants, to actually work with patients to enable them, empower them to keep themselves healthy. We all know in this room that there are many different ways to achieve oral health other than drilling, filling, and billing, et cetera. But having that conversation, organizing a system to do that, training the staff to do that. We've experienced it at the Oral Health Center where we do it, but it's time intensive, personnel intensive, and it has cost us a lot of money to prove that you can make people healthy and keep them healthy if you apply yourself to those social determinants of health. I think we have to figure out how can we make it affordable, and I think workforce and the utilization of different workforce models might help us there. The dentist should not be treating those patients and teaching them how to keep themselves healthy. Our staff can do that, and they love doing it. Yeah, that allows them to play dentist. Yes, they're more effective. Yeah, absolutely. No. Yeah.
Okay, thank you so much, Dr. Doherty.